Hi, today's video is talking about Sever's disease. Sever's is something that can affect pain around the Achilles tendon, typically in children aged around about 9 to about 15-ish in age. We're going to be talking about what Sever's disease is, what we can do about it, and how this can affect children. My name's Ali, I'm one of the physios from treatmyachilles.com. We are an online virtual physiotherapy platform offering appointments based on all types of an Achilles tendon problems and injuries. If you would like more information about our service or how to book an appointment, please have a look in the information below. So the title Sever's disease sounds quite scary and sounds also quite misleading, to be honest. I think the word disease here is probably a bad choice of words. It definitely doesn't mean something that is going to get worse. It definitely doesn't mean something that's going to spread or something that you can catch. What we're talking about with Sever's is a type of injury called a traction apophysitis. So traction meaning the forces going through the Achilles tendon where it inserts into the calcaneus, so the bottom of the heel bone, which hopefully you can see on a picture here. And what you're also looking at there is the growth plate. So in children, we have growth plates in our bones. That's how our bones grow, that's how they change in size, and they're really, really normal. And there's one of those in the calcaneus, in your heel bone. So as we get to about 7 to 9, that sort of calcaneal apophysis becomes more obvious. And then as we age and we get to around about 15 to 17, it fuses and that becomes the size it's going to be. So if we're getting a lot of traction, a lot of forces going through that area, particularly where that Achilles is attaching onto that calcaneus during our childhood, and this typically comes with activity, so where people are doing lots of different sports or lots of the same sport on a repetitive basis, and it's those forces that can irritate that attachment, make it feel quite sore, possibly be a bit inflamed. But the good news is this is self-limiting, so once that calcaneal growth plate has fused, then this problem goes away. Because we know when we're thinking about when that growth plate is there and when we're thinking about children being active, we typically see patients aged around 8 to about 15. We're also looking for symptoms in regards to whether it's one heel or both heels. It can be either of those things, and it's very tender right on that point where that Achilles is attaching into that bone. Typically children may be limping directly after doing activity or later that day, and it can also mean that sometimes they don't even want to put any weight through that heel and they stand on their tiptoes. It's very activity dependent, so you would typically be finding this definitely after sports or after PE at school, or a long time on your feet whilst also doing sports in that day. You typically wouldn't see this in someone that's been more sedentary or that basically sat still all day or overnight. It normally tends to be when there's been a start of a peak in a load. So a typical time would be when people are returning back to school in September and going back to all of the sports and activities in a school situation. So for teams, for PE, for practice, for out school of activities. Or it can also be at the start of a season where again training has ramped up and then fixtures have started if you're playing in team sports. You also could have a link to a growth spurt, because we know that different things grow at different speeds. So different bones, different tendons, different muscles, all can grow at different speeds in children. So if you have had a growth spurt recently, or your child has had a growth spurt recently and complains of heel pain alongside the activity, and it's a bit tender at the bottom, they may have Sever's. So it's then important to get somebody to have a quick look just to make sure it is that diagnosis. So what do clinicians look for? So you would take your child to see, let's say, a physiotherapist, and we would be looking for that typical history that we've just spoke about. So the age of the child, is it activity dependent? Where is that site of pain? Is it tender? Have they just grown? And then we're looking to make sure that there's not anything else, so that pattern fits with what we're expecting. Typically, people are quite tight in their calves, so in their muscles that run down the back of their calf, they turn into the Achilles tendon, which then attaches into the heel. And you may also be a bit tight in some of the foot muscles, especially if this has been there for a little while. There may be reduced movement of the ankle, so pointing your toes is called plantar flexion and pulling your foot back is called dorsiflexion, and it's in this position that we stretch the Achilles tendon, and it's in this position that we're contracting the calf and the Achilles tendon to do that. So not only do we maybe find some decreased range of movement or tightness in those muscles, we may also find weakness, and typically it's in the moving back muscles that you tend to find more weakness than the pointing down. There is some evidence base to suggest that possibly foot position is important in a child. Now, we all pronate, we all supinate. So what do I mean by that? We all have the ability for our foot to be a bit flatter and then to become more arched. It's about children that have maybe overpronation, and that's something that you would want to be checked by a professional, whether that be a doctor, a physio or a podiatrist, to see whether that is actually the case, rather than just buying anti-pronation shoes or insoles. So what can we do about it? What treatment is available? Well, a lot of this is education. It's education on this is very normal for active children. It's something that's self-limiting. It goes away once that child's growth plates have fused. It's something we can do about in the long term, but it's a lot about management of these symptoms. So one of the things we do first of all is to calm things down. So if we can calm things down, so symptoms become easier, the child doesn't limp and walk, they can, when they're walking, they can get back into a bit of activity. Now it might be that that activity becomes modified, and it's important that this then is a conversation with both the parents and the child as to what activity is the most important at the moment. Quite a few times we see children where they're playing for, let's say, multiple teams. So they're playing football at a weekend, they're also playing for school, and they may be doing training somewhere else as well, or indeed be picked for county or a different type of sports team. So when you look at the sheer volume of activity that they're doing, and PE and the things they need to do to walk around a school site, it may be that we can find little things that aren't their priorities that we can change. So fitness things, can they change from time on feet, so walking and running activities, to more offloading activities like swimming or cycling, or if they're an older child in a gym, like a cross trainer? Could there be things where we can modify the training sessions so they're not doing as much sprinting or jumping drills, and they can keep things a little bit quieter? If you're dancers, could you be marking out and then doing a few of the dances during a session, for example? So this is called relative rest, and this activity modification is the most key treatment to Sever's disease. So it needs to be understood by the child what is happening, why we're doing this, and how we can then try and keep them active. And this is also important that the parents understand that this isn't a serious injury. It's not something that's going to lead to something else lifelong, but we need to manage the symptoms at this present moment in time so your child can do what they want to do. So when we're looking at orthotics or other types of examples, the main role in this is looking at potentially calming down symptoms to start with, and then we started to talk about overpronation, so looking at what foot position your child has or they have and how that can be changed. So when we're talking initially about lots of different options, if this is an extremely severe case of Sever's that really isn't calming down with any other type of option, children can be put in a boot or something that immobilises that foot for a very short period of time. It just means it takes the load off. If it takes the load away, then symptoms start to calm. Think of it being a little bit like a bruise being pressed on every time they do activity, and therefore if we take the activity away, that calms down, that bruise starts to go away. If you then go straight back into activity again without addressing any other issues, you might be at risk of reoccurrence. And reoccurrence with severs is something that is quite common. So again, that information needs to be relayed to both patients and to their parents or caregivers, so we can work out a strategy of how to avoid that. And we'll come on to talk about that a little bit later. So again, that immobilisation boot is quite rare and most times not necessary at all, but it is in our toolbox. A second thing that's slightly better than that and more commonly used is something called a gel heel cup. And that gel heel cup, they're quite cheap. You can buy them from places online, and they sit in the back of the shoe, and it's just a cushioning gel type shape that sits in the back of a trainer or a school shoe, for example, and it helps just slightly lift that heel higher than the toe, so it's shortening that calf and that Achilles complex for the short term only. This is not a long term thing. And it's also cushioning that heel bone, so it can make it feel more comfortable. If we're then looking at, well, are gel heel cups the best thing out there, or would it be better to go and see somebody in regards to foot position and whether the child needs orthotics? Well, there has been a recent study, and the recent study looked at both of those things, and it highlights that the use of custom-made orthotics against other treatments were really useful when they were used for about a 12-week period and can really help with pain relief when comparing the two things. But the authors of this study tend to then go on to say, actually, this needs to now be the custom-made orthotic compared to things such as the rehabilitation, like strengthening or stretching, or the orthotics compared to any medication or anything else that we're doing as a treatment. So this study didn't look at those things, it only looked at the difference between custom orthotics and heel wedges. So if your practitioner that you've seen has pointed out that there is a foot position where overpronation is more common in your child, then that might be something to look at for an orthotic prescription for that person, for that individual. So Sever's is not an Achilles tendonitis. It is something very different. It is related to growth spurts, like we said, and it's over that area where there's that growth plate and where that Achilles comes down and attaches, and where it takes all the forces when that child is doing their activity. So there is an element of inflammation that has been found, particularly around that localized area to where it's tender. And therefore non-steroidal anti-inflammatory drugs may have a role here. Now, this is something as a physiotherapist that I'm not trained in, so it is something that I would always suggest that you speak to a pharmacist or your GP or doctor, depending on where you are in the world, to discuss whether these medications are appropriate for your child, with any other medical illnesses they have or any other medications they're taking. One thing to consider is talking to that practitioner in regards to whether it's worth taking it just when they're doing activity, or taking it little and often when it's painful, or taking it as a course over a few days to settle it down. And this might be different depending on each person and also how severe that problem is. Another good option to settle things down are ice packs. So ice packs, as long as they're wrapped in a towel and therefore not at risk of giving yourself an ice burn, they are really quite useful and safe things that you can use, and also children can use. There's a fancy term called cryokinetics, which basically just means ice with movement. So icing before they do any exercise or after doing exercise can feel more comfortable. So that ice is helping that person calm down that pain, and then they can go away and do more, and then they can calm it down again by using that ice at the end. It can also be used in rehabilitation like that, with the exercises you may well have been prescribed, so you can ice, exercise, ice. A thought process, if there is swelling and inflammation there, and again that would be local to that area, not a whole foot, you're looking at doing the ice to make things feel more comfortable, the exercise to get your circulation going so it whizzes through your body and it sends new circulation to that area and takes that old circulation away that's irritating things. And then after you've done that, you calm things down by using your ice pack again. One of the main things that we might find when we're discussing about rehabilitation is the tightness of the calf muscles or the foot muscle when we do certain tests. So those tests won't be just that the child is reporting that tightness, or if we prod on that calf we might think that there is some tightness there, which is very difficult to diagnose by just prodding on it. It's actually looking to see whether there is decreased range of movement with when you're pulling your foot back towards you compared to the other side, both in a standing position with a leg straight position and a leg bent position. All of those are important because you have two calf muscles that that turn into that Achilles tendon. One is your gastrocnemius, which is biased more with a straight leg because it attaches above the knee, and the other is the soleus muscle, which attaches below the knee and therefore is more biased with bent leg type movements. If that's noted, there has been lots of school of thought, and it's very traditional with Severs to do lots of stretches. This is interesting to me because it's the absolute opposite of what we know when things are insertional with Achilles tendons and Achilles tendinopathy problems. So to me, the jury's out a little bit on this, but there isn't much research out there, if any, to have a look at it to see whether stretching is a great idea or not. So if you were to put the stretch through that calf and the Achilles, actually what you're doing is pushing that Achilles tendon closer to that calcaneus. So when you're pulling your foot back into that dorsiflex position, if it's again that analogy of pressing on a bruise, you're bringing that bruise closer to where it inserts. So it can be a little bit more uncomfortable. It's the opposite of us putting that heel raise, for example, into the boot. But as I said, most of the traditional physiotherapy or rehabilitation, which is what's mentioned in the literature for trials when they look at rehab, includes these stretches. So what else can you do to help relieve some of the tightness in that calf? Well, it's looking at the activity modification, it's looking at warming up correctly, it may be not holding stretches, but making sure range of movement exercises are bringing in, and it's also can be massage to that calf area or the foot, which could be done by a therapist as well, or you might be able to self-massage at home or use different equipment that you might have, like a foam roller or a golf ball or a tennis ball or one of the massage guns. So we've talked about tightness and mobility in regards to rehab. The other side to it is strength. So again, typically in the research when looking at Severs, they've talked about dorsiflexion, so the pulling back possibly could be weaker. So if you think about a seesaw with muscle groups on either side, you've got your pointing your toe muscles on one side and the pulling back muscles on the other. If one side is tight or sore or a bit weaker than the other, it has a knock-on effect to the opposite muscle group. So it could be that we need to strengthen both of those muscle groups or just one. It may be that we can do some exercises to help if there's any pronation noted, to help strengthen in that foot or in that arch. And also it's probably worth looking at the rest of that body, so the rest of that chain. Nobody does exercise with just an Achilles tendon or just their heel. We look at and use our body all the way through. So your Achilles at the bottom, next to the calf, next to the hamstring, next to the glute, makes up that whole posterior chain of your leg, and that posterior chain helps with the push-off type movements, the explosive run type movements, jumping and sometimes landing. We also then want to look at the opposite side, so the other muscles that you're using within the sports that you're doing, and this will be sport specific, and have a look at not just how strong they are and how long they are, but how well you control those movements. Is there anything that you do where your hips are lined up with your knees, that are lined up with your feet, or what's happening in that arch when you're doing certain movements? So a rehabilitation program is very common. It is very standard, and I think it's pretty necessary to help people get back into the sports and activities that they want to do. So now we come on to the prevention side to things. This is super important because absolutely no physio wants to see somebody on repeat because they're flaring up every 5 minutes to calm it down. No patient wants to go through cycles of pain where they can do their activity and then they can't do their activity. And no coach or people that are running the sports also want to lose their important players or competitors during that time. So it's really important now to look at what's going on and how can we prevent it. So training errors are really, really good to note. We already said at the beginning that it typically happens when there has been a return to sport or the start of the season, for example, so after the school holidays and then they go back to activity again. This is like a peak in a load. So if you're bumbling around used to doing activity at this sort of level and then all of a sudden it suddenly peaks, or you've been poorly or been off on holiday for a bit and then you go back to your normal activity, that's a sudden peak. Or you may have changed the type of training. You've gone to running and you're suddenly doing hills, for example, or in your warm-ups for netball, they're suddenly doing lots of sprints, for example. So it's about if there's been a sudden change in that loading of this area. So a good guide would be that change, whatever that might be, it might be time on feet that you're measuring, it might be miles or kilometres or step count that you're walking, could be elevation of different hills, it could be how much jumping you're doing and how high that jump is and how long that jump is. However you're measuring it, you're looking at trying to keep a 10% increase each week. Now that 10% increase comes from some running literature, but it has been shown that anything that jumps more than 30% can help to irritate injuries over a period of time. So that's one of the warning signs we look for with anyone with an overuse injury. An injury without an accident or an incident that's related to activity is called an overuse injury. Has there been a whacking great jump? So 10% for each week is a really nice way of looking at it. If you can't control that because your coaches are running your sessions, maybe you can have a conversation with them about how many minutes of activity that you will perform at your highest level, at a low level, or sit out for. Or maybe there can be ones where you say, I won't go to this session, but I will go to these sessions because I'm not fitting my 10% in. It's worth having conversations with teachers at school or PE teaching staff, again, for that same reason that there may be some modifications happening within sessions. There is some school of thought to say go up for 10% for 3 weeks, and then in that 4th week, not stop altogether, but have a more restful week. And therefore that allows you to have a take stock and see what's happening. Warning signs could be that you're living with a little bit more discomfort if you compared how much out of 10 you were having pain last week to how much out of 10 you've been having pain this week. It might be that you've had more bad days than good days, or it's taken a number of more hours or minutes or days to settle after a large amount of activity. So any of those things that are creeping up or creeping into more intense pain is a warning sign that you may end up with a bit of a flare. So this is another activity training error, which is called a boom and a bust. It hurts, we stop, we take away that pressure from that bruise analogy so everything settles down, we go back to activity, our peak and load happens again, all those forces go through that Achilles tendon and that calcaneus, ouch, that pain comes back, now we have to completely stop again. So we're booming, busting. What we're trying to do is keep everybody at an even keel of a 0, 1, 2, maybe 3 out of 10 pain. So enough that that person isn't really limping, enough that it hasn't changed their plans that they had for that day, and enough that it hasn't changed the function, the range of movement that person can do, how well they can run, how well they can jump, etc., etc. Our final part of our activity training errors is to look at the intensity of the exercise. And with children that are really keen to do activity and adolescents really keen to do activity, and those that are really competitive, quite a lot of their activity is quite a high intensity. So a good guide is to look at, again, the number of minutes of activity in a week, and you're roughly looking at 80% being that low to moderate activity and that 20% to be that high activity. So if we looked at a scale where we're looking at high activity being where I can't get my words out and have a conversation with somebody, the middle being I can say a few words and then I need to stop talking and keep going, and the bottom bit of activity where I could have a conversation like I'm having with you now, we're looking at keeping in this bottom part of this scale for 80% of the time and this top for 20% of the time. So again, that's a good guide for coaches if you're trying to plan what things to stay out of in sessions or what things to stay in with sessions. So it's always worth that communication and that dialogue. If you can have a look at your week and work out rest days, that can also be useful. So rest days are really great directly after the most intense day of the week, or they could even be the day before a very important fixture or competition that's coming up. So they are important to schedule in. Again, it gives you that chance to say, how am I? Is my function okay? How's my pain level compared to last week? But it also allows that activity modification, so we can cherry pick the activities that are the most important. If we move away from looking at training and activity, other things to look at is making sure general health is pretty good, we're not coming down with anything, that diet has been great, hydration is on point, and that sleeping is going well too, because this all can affect how we perform and therefore what pains and pain levels we might be feeling as well. It's looking at, are we using the most proper equipment? So are we training on really hard floors when we could be on softer, more sprung floors? Can we have a look at what surfaces we might be doing activities on? Are our footwear in date? They're not worn, they're not the wrong size. So a rough guide for trainers for adults tends to be around about 500 miles, for example, if you're looking at runners, or 6 months, whichever comes in first. So a good way is to look at the sole of the shoe, and if there's areas that are particularly worn more than others, it may be time to replace that footwear. If you're doing barefoot sports, is there a way this can be modified by changing either the surface that you're practicing on or footwear for some of the warm-ups and cool-downs, for example, but not for some of the main activities? Can you maintain flexibility? So are you good at stretching? Not necessarily just for warm-ups, where we're talking about should you hold that stretch or should you just do movement-based warm-ups. There's some videos on our sister site called Sports Injury Physio that talk about that. If you have a look at keeping that range of movement and keeping yourself nice and flexible, again, we can avoid some of that tightness in that calf and that loss of range of movement. It's also been a thought, and this is something that's not necessarily looked into greatly in just for Severs, but it is a discussion for children about single sport specialising too early at an early age. So they're saying if the same forces are happening on repeat on a child's body over and over again in a week without a different type of sport or activity occurring, what is going on in regards to this and Severs, that's unknown at the moment, but there is lots of discussion as to whether single sport specialisation is a great thing for children and what age is a great thing to start to specialise in. So the absolutely really good news with this is that it is self-limiting. Therefore, it doesn't cause problems for the rest of someone's life. It goes away. There's no sign that it necessarily sets you up for Achilles tendon problems or any other heel problems later in life. It tends to go away around the time that growth plate has fused, which is that late teenage years, and therefore it disappears on its own. So it's understanding that, and that part can be quite reassuring in itself on how to manage this condition.